Cracked teeth. That's become an epidemic in dentistry. There's not a day that goes by that I'm not treating at least one fractured tooth.
I agree. It's almost more common to not have some type of fracture than to actually have one. So I'm glad we're discussing this today because this is something all dentists are dealing with.
Welcome back to For the Love of Endo. I'm Dr. Bill Nudera.
I'm Dr. Brett Gilbert.
And we're here to elevate endodontics one conversation at a time.
So cracked teeth, Bill, this is something that we literally can't get away from. It's coronal cracks, obviously very, very prevalent. But let's talk about the cracks that extend down onto the root surface.
The cracks that make a difference when they get pulpily involved. There are a lot of different reasons on why we may fracture teeth. I think one of the biggest things that we're seeing most recently, we're all seeing fractured teeth more.
Yeah.
Stress. Right?
Yeah.
Stress, and where we carry our stress, grinding, clinching, overload of tooth structure that the teeth were not designed to take. Now you put a restoration in there, little small occlusal class 1, or maybe it involves either the mesial or distal marginal ridge. Now we've lost more structural support and we develop those fractures, and then it becomes endo. So by the time we get involved with it as endodontists, we're at the end stage of the disease process, right? So we see all these things at their worst, and now we have to make these decisions with the patient. Do we move forward? Do we make the attempt to treat these teeth or not?
Yeah, it's a good point. And I think there's some varying opinions. And, we had an opportunity to sit down with Dr. Lou Berman. And, what I think this episode is about, what we're going to get into is the cracks we see. Mm-hmm. Okay. But Dr. Lou Berman had a really incredible insight on the cracks we can't see. But under his sort of study and what he went to painstaking effort to actually collect the evidence was to show that there are a lot of these really hairline fractures we can't see, but ultimately doom the tooth.
He published that in the Journal of Endodontics and labeled this phenomenon called fracture necrosis. And fracture necrosis is defined as that tooth that either has no dental work done on it or just a shallow restoration on it and has a necrotic pulp. One of the things I like to do, and call me an endo nerd or not, I like to read old textbooks from the 80s, right? And one of the diagnostic terms that they would use in the 80s was spontaneous necrosis of the pulp. There's no such thing as spontaneous necrosis of the pulp. It's like spontaneous combustion. I mean, I guess some people do believe in that too. But either way, there's always a reason on why the pulp behaves in the way it does. And it's always traumatic from caries, traumatic from dental restorations, traumatic from blunt trauma, traumatic from sustained trauma. Everything is trauma.
Traumatic from occlusion?
Trauma. Just every reason why we're doing a root canal on any tooth leads back to some traumatic event that the pulp just couldn't recover from. Okay. And fractures now put us in a different position because fractures are permanent fixtures on a tooth that last forever. And I think a big misconception that patients have is, once I get this treated, the fracture's not going to be a variable anymore. No. So the way I frame it during my consultations is if I'm treating a fractured tooth, I'm treating symptoms associated with something greater, something that caused that fracture in the first place, that if you're going to still have that behavior or do that thing that caused you to fracture your tooth, that is going to decrease your prognosis, even if we do make the attempt to try to retain that tooth.
Yeah, so I think something really helpful would be, let's go back and listen to Dr. Lou Berman describe fracture necrosis and kind of how he went about the process of actually getting evidence to support this, what I think was a presumption or a suspicion that he had that he ultimately was able to show is a reality.
First of all, the fracture necrosis was a term that I coined, actually, meaning that a tooth would die because of a fracture. Not because of deep caries or because of trauma, but because of a fracture. I was frustrated in practice just like you are. I would see a case that I treated nicely, 5 years ago, and it comes back and it's, there's a fracture in there, or there's a huge amount of periradicular bone loss all the way down to the apex to the crestal bone. I'm thinking, what the heck is going on with this? And I would tell them, I won't charge you for the consultation if you bring me back the tooth.
Ooh, love it.
So they would bring me back the tooth, and I'm looking at it, says, it looks fine. I would put it in bleach, I would dry it, and I would see this hairline crack going down the long axis of the root of the tooth. I mean, so small. But when you think about it, if you can see it, it's not as small as you might think. Then it's an avenue for bacteria to get into and cause that tremendous amount of bone loss. So then I kept doing that and I kept seeing the same thing. It was almost 100% of these teeth that I thought I did a really good job on, that were nicely restored, and they would have a crack in there that I could see after the fact. So then I took it to the next level, and maybe I shouldn't have, but I did. I would have somebody come in that would have a virgin tooth or practically a virgin tooth, and I can't really see a crack or a fracture just clinically. But I would tell them, your tooth is non-vital, the tissues inside there died. And the only thing I can think of that would cause that tooth to die, because you don't have a restoration in the tooth at all, would be a crack or a fracture. I'm going to tell you, I don't think that the success rate for what I'm going to do is going to be all that great. I don't know that I would do it either, but I'm not going to charge you for the consultation today or the x-ray. After you have that tooth taken out, bring it back to me. I did this 27 times. Before I sent them away for micro CT, I put them on a model trimmer. So I would shave off about 3 or 4 millimeters of the coronal part of it, and I could see a hairline crack that went right down to the pulp. I said, I think I got something here. So I kept it up, and it happened over a long period of time. I would say, give me the tooth. I would send those tooth down to our buddy Sergio Cutler down at Nova University. Give me a micro CT. A micro CT is different than a regular CBCT. CBCT will give you a resolution, a cutting of about every 70 microns, 80 microns or so. But the micro CT is about every 6 microns. That's really small. 100% of those teeth that we put on the micro CT came back that there was a fracture that went right down the pulp, through that percation area, and down off of a lateral side of a tooth, just like you would expect to see the bone loss in a situation like that. So we put together a paper on it and saying that if it's got no restoration and no other reason for the pulp to be necrotic, in all likelihood, this was 100%, you're going to have a crack or a fracture in that tooth. Now, you might be able to save that tooth, but when that tooth goes south, after the root canal is done, you're going to have a huge amount of bone loss that's going to compromise it for an implant. So my thought was, let's get those teeth out of there. I don't think there's a great prognosis, and have that done before you have that dramatic amount of bone loss, because once you lose crestal bone, it's really hard to replace, and your implant prognosis is going to be less. The paper was considered controversial when it came out, and on the first round of review, it was not accepted. One of the people that were on the scientific advisory board, one of the directors, he was pretty adamant that they thought that this paper had some importance to it. And that's the reason why it was published.
And his recommendation for the teeth was what? Tooth extraction.
Cool. Yeah.
And his recommendation for the teeth was what? Tooth extraction.
Cool. Yeah.
Yeah, because his outcome or his conclusion was that the prognosis for these teeth isn't very good. The morbidity of losing the bone support around this fracture line 2-3 years out, and monitoring this, it affects that potential implant that the patient could get. But that's just one study. What about the other side of the house? What about the study by Davis?
Yeah.
Where he actually looked at fractured teeth and says, well, you know what? I've got some teeth here, probing depths, isolated 7 millimeter probing depths. Let's try to get some success to these things. And he's doing the endo. He's doing what I call pseudo posts, where actually you bond restorative material down into the canal, trying to get
below the level
of the fracture to try to get some bond strength in that root. And he's got some really great long-term follow-ups on these cases. So we have one area of the evidence that says, well, fractured teeth, they're not going to work. And another area of the evidence that says, well, fractured teeth can work. So where's your position on this, Brett?
Well, they're kind of two different things, because to me, what Lou Berman's study is showing the fractures that you literally can't see. Like if anyone establishes an exam, radiographic, CBCT, clinical, it's really hard to tell. Whereas Davis is like almost like you're staring right at the crack. But I think Davis's study is really paramount, because it didn't just describe the problem. It didn't just describe technique. It also described factors that we can control as the clinician to help protect the tooth, but also put some onus on the patient in the protocol. What they really found basically was survival. They had survival and success criteria. The success was very stringent. The survival was a little looser, right? pain-free, still in function, etc., and found that they basically were the same almost over 4 years, and showing that the retention of the teeth was almost the same as teeth that didn't have cracks. So what's really compelling, Bill, both of these studies, private practice clinicians. We think of studies coming from a university and a lab, but there is a tremendous opportunity in our space for the clinicians that are seeing, like Lou said, I kept seeing these cases. I kept seeing them. So finally I said, go get this tooth out and bring it back to me. I want to have it. And then he studied them. So I would love to hear from his own words how he described it to us on the floor of the AAE, and kind of give the audience an opportunity to hear it straight from his words.
You're bringing up this point about how these two studies looked at Davis's study with the fracture staring at the face, and Berman's study where you don't really see the fracture. Intuitively, I would think that a tooth in the Berman study's position would be better off. If you can't see the fracture, you know it's probably there just by looking at the radiograph and interviewing the patient of their history on how they were now led to the point where they're at your chair. But you would think that the fracture isn't visible. The subclinical fractures, they would have a better prognosis, wouldn't you think?
You would think, except that doesn't seem to be what's actually playing out.
That doesn't make any logical sense.
It's counterintuitive, but in a prior episode, you were talking about a patient where you had tooth number 3, it was vital, you did endo, lesion on the mesial buccal developed. You got MB2, all of it. You retreated it. No, sorry, you did surgery on it, and it still didn't. So we think of fracture necrosis, and it's a necrotic situation, but what about these same types of fractures in a vital case?
I think that may be the difference.
And so there's this one outlying part that is hard to define, it's hard to diagnose, it's hard to detect. And that's why we have to explain to patients that biologically we can't make a prediction every time. And this might be one of those parts that could bite us, but in the absence of its presence, without being able to see it, it's too small to get that 75 micron diagnosis on CBCT. It's just a hidden thing.
So when you're seeing a patient that clearly has a fracture of some kind, or you believe that the tooth is fractured, how are you looking at this from a pulp status standpoint? Necrotic versus vital. Is your conversation different? Are you looking at the treatment options being different? Are your recommendations different?
So if I take it back, so it's a great question about the pulpal status and the status of a crack. So if we take it back to the very basics, we have too many dentists that graduated dental school thinking that a J-shaped lesion is a fracture. And in reality, in that instance, the necrotic diagnosis really opens the door that this could be drainage through the sinus tract, as opposed to a vital case where if you have a J-shaped lesion and you're convinced that this tooth is giving you a normal vital response, now you have a different sort of understanding. So in that sense, I think it's important. But in a typical marginal ridge fracture, a molar, we're trying to decide save it or not. The vital versus necrotic diagnosis doesn't really impact my decision making. Does it for you?
So you're telling me that you're approaching these cases with your patients and your treatment approach the same regardless of the status of the pulp?
If it's a visual crack and they have endodontic disease at whatever level of the continuum, I'm going to approach it the same.
Fair. And I think I would too. Now let's throw out the scenario of the tooth that has no restorations. The tooth that your diagnosis is vital or necrotic. Does that pulp status affect your clinical decision? Because according to the fracture necrosis study, Berman, unfavorable prognosis.
Yeah.
Right? Unfavorable. Yeah. Right? So if it's vital, does that mean it's more favorable?
It's a great question. I think, I don't know that you can have a general response to that as much as an individual. The fracture likely still exists. At that point, you're not really seeing it, right?
No.
Now, if you can see it, does that change it for you?
So these are all really tricky questions that I don't think we really have
it's fair, because without a case, a patient, an occlusal pattern, an image, a CBCT, and an understanding of other histories, it's hard to say, because, what I found is parafunction is not as easy to diagnose and discover as you think it would be, based upon not spending time with the patient, not seeing how they function, whether they grind or clench. We know that, like you said previously, the epidemic of clenching and grinding and cracked teeth it was something I had an opportunity to be on the news, NBC News in
Oh, really?
Chicago, talking about the epidemic within the epidemic, which is to say that we have seen more fractures. I think the statistics showed 30+% increase in fractures detected after the pandemic from before. And so going back to that emotional, the body basically keeps record of the emotional distress we're in. So our bodies store emotions, and these masseter muscles and this jaw tension, it can cause a lot of shifts. And, the mandible is so unique. It's a, diarthroidal bone, right? So you have two joints in one bone, all controlled by muscle and cartilage. And so when you start having bite issues and you start clenching and grinding and the muscles get out of balance, things change very fast. So all that to say is that every scenario is very unique to that patient. And so we have to work with the GP. We have to work with our own spidey sense to kind of pick up, is it possible that this is a fracture and I'm just not seeing it? And if you have no other evidence at all, maybe you are a little more, give a little more leeway to what's possible. But if you're seeing that this has been happening with this patient, then I think that at that point, Dr. Lou Berman may be right. Maybe it's better just to pull the plug.
Well, I try to put the ball in the patient's court as much as possible. Now, there are ways to frame uncertainty, right? In reasonable terms, right? I know we can't predict the future, but we also don't want to make the decision for the patient. Now, clearly, if it's not going to work, it's our obligation to tell the patient, hey, this is not going to work. We shouldn't even bother. But those aren't the cases we're talking about. These are those gray area cases where the patient's coming to us with the possibility that something could work, at least for some given period of time, may not be forever, right? But at least some given period of time. And so one of the ways that I like to frame again, it comes back to conversation, is how motivated are you to try to save your tooth? Because if you're motivated to try to save this tooth, here are the next steps we need to try to take. I can't guarantee it's going to work. I can control the technique, but I can't control how your biology is going to do. But we can do our best to try to stabilize this to get as much life out of this tooth as possible. And it's up to you now whether or not you want to take that risk. The other thing that I've been more cognizant to is the medical histories, the selective serotonin reuptake inhibitors. Some things like Paxil, what's another one? Lexapro. All these other medications to control behaviors and anxiety, ADHD, PTSD. They're more prevalent on the market. The amount of prescriptions that have been written over the last couple of decades have been significant. And why does this matter? Because one of the side effects to the selective serotonin reuptake inhibitors is nocturnal bruxism. I'm looking at that, and if the patient is taking these selective serotonin reuptake inhibitors, they're coming in with a fractured teeth, that's part of the conversation. I could treat the symptoms associated with your cold sensitivity because you have cracked tooth syndrome, but you still got the cracked tooth. You're still taking your selective serotonin reuptake inhibitors. And I also say, if you're not wearing some sort of occlusal appliance to address some of this nocturnal bruxism, we're dealing with this one now, but it's only a matter of time before we're dealing with another one later. So now the fate of this particular tooth may have been determined for us already, but the fate of your other teeth may still have an opportunity to try to mitigate. So I always try to get the referring dentist involved as well and let them know that, hey, let's get this patient fitted for a nocturnal grinding device. But that also begs the question, not every patient can tolerate those. How many patients have you seen that, well, I used to wear one, but I can't wear it. They're too bulky. I can't sleep with it. So now it becomes a trade-off. Do you want to acclimate yourself to getting used to wearing this thing, or do you want to start losing your teeth? And then they say, well, I'm just going to wear one of those Essex retainers because I just had Invisalign, so I'm just going to use my last Invisalign tray. Hey, that's better than nothing. Yeah. Right? Is it as good as a professionally fit bruxism device? Probably not. But it's certainly better than going over the counter and buying one of those little rubber squishy mouth guards. Yeah. We do what we can to educate our patients on what the realistic options are and what the realistic risks are. And if they're not willing to take that risk and want to make that attempt, and they're not motivated to save their tooth, then I'm going to say they may not be a candidate for my treatment.
It's fair. That's fair. But what I will say is it is nice because it's really only been in the last maybe 10 years that we've had the evidence. So now when I'm presenting to a patient, they have a marginal ridge fracture. It's 2 to 3 millimeters below the crest. CBCT, I can confirm that with that little vertical black notch, right at the level. you often don't see the cracks, but you see the bone loss that's associated with it, which is beautiful. And so being able to then measure that, making sure that I am bonding deeper than that crack extends, being able to build it up, being able to reduce the occlusion, getting a proper restoration, having that study really creates an opportunity to present to the patient, look, the statistics would show that over 4 years is a good chance this tooth will be retained. Yeah, and that I think is more important for our decision making, is again leaning on the evidence basis. On the flip side, if you're like, you know what, I've seen too many of these, they don't work, then you have Lou Berman's study to give you fraction necrosis.
Well, that's a good point. The literature is going to support whatever decision you need to make. But I've got 2 follow-up questions for you, Brett, with that. When you're doing your consultations for fractured teeth, do you go into the statistics with your patients?
Yeah. Oh, if it's pertains to the discussion, if it's something that might help them see the potential, I will. And I'll also explain that we used to just extract all of these teeth. And thank goodness we stopped doing that, because you're seeing the follow-ups and seeing that the teeth are doing well. I think it's important to understand where, again, a private practice study, this one in particular by Matt Davis, is just showing us that there is a much greater opportunity to save a cracked tooth than we thought. And again, I want to acknowledge a private practice clinician developed, designed, and executed a study that actually turns into something that other private practice or public health or any type of clinician can lean on to say, you know what, ma'am, I can't tell you for sure that you will have this tooth in 10 years, but I can tell you that there is a great chance that in 4 years you'll still have it.
And I think those private practice studies are way more valid for the trenches than the institutionalized studies, 100%. So back to this, the consultation with the patient, and you're throwing these statistics out to them. Do they understand what you're saying?
Yeah, I think it's more, I always say something to this effect. You know, I'll say, Mary, the reality is that there's definitely a gray area here, and you are within it. And what I can promise you is that if you were beyond the gray area, we're not having this discussion. I am not going to try to treat a tooth that I believe has no chance of being saved. So now how deep you want to go with that is up to you, because the honest truth is the only definitive answer, the only definitive treatment that is 100% predictable is we remove your tooth.
You bet. That's the most successful dental procedure, unfortunately. All right. Second follow-up question is, when you're treating, the patients accept your treatment, say, yep, I want to save my fracture. Dr. Gilbert, you're the best endodontist ever. You can save, you can fix my tooth. You're going to do the root canal, get me out of pain. Now you see the fracture. Now you're in there. You knew it was there. No big surprises. What are you using as your material to bond inside the canal?
That's a great question. So, and this is, again, if anyone's listening to this and you have something that you're doing differently or think might be better than what I described, please let me know. I would love to learn more. So what I typically do is I will make sure that I have great visibility, of course. I'll use something like etchant, down throughout the whole thing. And then I'll use like an OptiBond universal, like a, etch prime bond, all of it. I'll make sure that I place it down. I'll obviously light cure that. And then I'll use a Centrix tip with it's a material called multi-core flow from Evaclar. What's nice about it is it's of all the materials I've tried, Bill, there's the least amount of bubbles that form with it. And with the Centrix tip, I can bend it and I can literally put it right up against the gutta percha, and I can actually see it expressed on top of the gutta percha. And then with a slow withdrawal, I'm able to get a very smooth, homogeneous type of filling down into the top of the root canal and to the level below the crack. And then you can either continue the full core buildup with that, or you can switch to some other core material, but that's how I place it. Does that differ from what you do?
A couple questions, very, very similar, but a couple key things that we need to kind of bring up. How deep does the curing light penetrate to cure your material? Is this dual cure you're working with?
Yep.
Even the OptiBond that you're working with?
No, not the OptiBond.
So that's the concern I have too, because I they make a lot of etch-free composites or the bond, the adhesive dentistry is really expanded light years. I use Gerrestore basically for that. The exact same process as what you're doing.
You find it flowable enough?
I find that it works for my needs, but it depends on how bright my microscope light is. Even though we're using those Centrix guns, we use them too with the orange filters. You have those too?
Yeah,
because they make a lot of different types for that. But the orange filter is supposed to decrease or increase your working time, decrease the setting time. I find that at one of my practices, that microscope light is so bright that I have less working time with it.
Mhm.
And that's what was frustrating for me in the beginning. But I guess my point is here is these processes are wonderful, but we have to make sure the material's setting.
100%.
Right? So using these dual cure products are going to be more advantageous, especially when we're doing these deep bonding into the canal. So,
and one quick caveat, I also have a second bonding agent that I'll use in situations like really small access openings, or maybe this prevalent, it's called Tokiyama. Have you ever had that? It's a cure-free bonding material. So basically you just paint it on and then you just do a slight airflow and that's it.
So it's a chemical thing?
It is. It does not require light curing.
So that could be a game changer.
Yeah.
You know, so we can probably put that in the show notes
Yep.
for people that are looking for that. It's, you know, they also make some type of composites now or materials that have like a ribond in them too.
Mhm.
So, I mean, there's adhesive
Yeah.
dentistry, like I said, it has come leaps and bounds. And it's also important that the patient has to follow through with their full coverage. You know, the endo, these pseudoposts, these deep cores that we're placing in there is only a fraction of what we need to do. We glue it from the inside and we hold it together like a ferrule on the outside. But we have to remember that it doesn't remove the fracture.
Right.
It just delays or prevents propagation of the fracture.
Nor does it change the habits or the circumstances that cause the fracture.
That's the problem.
But real quick, as an aside, so one of our sponsors, Vista Apex Solutions, they have recently acquired Ribond. I don't know if you were aware of this.
I was not.
And one of the things that I'm really excited about experimenting with is exactly what you said, which is they're talking about doing pre-cut Ribond pieces that we could use in this exact fracture situation down into the canal, along with bonding and along with resin, as a way of further fortifying. And I have some curiosity about how this will play out in long term, but I want to acknowledge our sponsor, Vista Apex, for coming through with, you know, materials that we can readapt to new uses that maybe weren't previously thought of.
We've talked a lot about, you know, studies with Berman's study and Davis's study, how we treat them, these pseudoposts, prognosis, all that stuff. How do we diagnose a fracture? I think that's critical too. What tools do we have to diagnose?
Yeah, well, I think one of the most important ones is, you know, being able to zoom in with your microscope and just evaluate the tooth structure.
Magnification.
That's
Okay.
low-hanging fruit. Obviously, as we mentioned, CBCT is critical because even though we can't always pick up the how small the crack, sometimes we can. You can see it through the enamel, through the dentin, but other times you can't. But the bone doesn't lie. That bone and PDL are just such sensitive creatures to that interface and connection with the tooth. And then lastly, I mean, from a symptom standpoint, I still rely on a tooth sleuth. I think a tooth sleuth is a very valuable diagnostic tool. There's always these cases, Bill, where patients are like, I have pain when I eat. And you do the percussion, palpation, probe, mobility, cold, everything's normal. You're like, what's wrong with you? It's a fracture. It's the flexure of those cusps. So
cracked tooth syndrome.
yeah, exactly.
Right?
Yeah, or I think they've updated that to cracked tooth condition at some point.
I see. I've learned something.
Yeah. So that's basically all you have to work with. Some of this is, I also say to patients, listen, I won't know the full extent of this situation until I get inside. Because you can see the internal surface of a root, you cannot see the external surface. And so sometimes, and even in the old days when we didn't have CBCT, et cetera, it'd say, hey, let me get in there, let me clean it out, you'll feel better, but it'll give me a greater sense of understanding the prognosis. So
we do the exact same thing here. And so when somebody comes in and says, I have a functional pain problem. So as we separate diagnostic testing into two categories. You have a functional pain or you have a thermal pain. And sometimes they have both, right? In my opinion, functional trumps thermal, because now you can start going and testing PDL tests with cotton swab bite tests, percussion tests. You know, when we start doing cotton swab bite tests, you're chewing, you're putting pressure on that cotton swab, but you're also stimulating muscles, you're loading the joint. So there's other variables in there. So a pure PDL test is strictly percussion. So if somebody comes into me and says, well, it hurts every time I bite, but I can't really find out which tooth it is, we go through our protocol. Cotton swab bite test first, no results. We can't find anything. Then we go through our percussion testing. No results. So now we know that maybe the PDL is really not involved. Okay. So the third level of pressure testing I do is the bite stick, the tooth sleuth, and we start putting on different cusp tips of the same tooth. And what's the symptom we're looking for, Brett?
Just a sharp pain, usually more on release.
Pain on the release. That classic pathognomonic sign of a fractured tooth. And when we can find it, great, we found the source. But let's say we do that test and the tooth sleuth or the bite stick test comes inconclusive. Then the next level of testing that I typically do is a cotton roll chew test, almost like simulating them chewing gum or chewing some sort of food in that area. Because if they have a functional pain chief complaint and I can't light that tooth up with a Q-tip, I can't light that tooth up with percussion, I can't light that tooth up with a tooth bite stick test, I'm starting to think nanodonogenic. I'm starting to think myofascial, could be joint loading. And what I'm trying to do with that cotton roll chew test is try to simulate
That's good.
that particular scenario that patient's feeling. And I'll say sometimes it works, sometimes it doesn't. But if I can't find the tooth, what do?
You don't treat.
Nothing. No treatment is better than the wrong treatment.
Yep. And you can always revisit, and the same thing with symptoms. You can always come back the next day. You can always, but what you don't want to do is make a commitment, have liability and a responsibility associated with something that you aren't sure about. Because what we have learned, I have certainly learned this, is there's nothing worse than presenting treatment, performing treatment. Treatment goes great. Symptoms do not change. That is the last place we want to be. And that's why, and we love our episode, diagnosis is the real procedure. That's why. Because you have to get the diagnosis right. Once you have the diagnosis right, you can play out all the individual steps, but you can play out all those steps perfectly. I always say, hey, looking at that x-ray, it feels like you hit a great golf shot. You feel that magic until you realize you treated the wrong tooth. And there is nothing worse than that.
Brett, have you ever treated the wrong tooth?
I have.
Me too.
Yeah, it's bad.
It's bad.
But it's also a part of learning, because every time that's happened, I have to go back. I have to rethink. I have to recalibrate. What led me there? And sometimes it's as simple as putting the rubber dam on the wrong tooth, right? You did everything right. You diagnosed it perfectly. You just put it on the wrong tooth. I've done that too. It's a bad feeling. What does it do? It makes you withdraw back and say, how did that happen? What can I do to prevent it? I cannot allow this to happen. And that's something that I think is the pain of learning. And sometimes it's the only way to learn.
I think we're going to really dive deep into that when we get to our episode about complications.
Yeah,
all right.
absolutely.
So granted, we've done everything. We've had every complication imaginable between the both of us.
Yeah. And maybe some we haven't even had yet.
Maybe. But we're going to dive deep into that in a later episode.
Yes.
But to circle back and kind of close this episode out today, not all fractured teeth need to be removed. Not all J-shaped lesions are fractures. Okay, so let's use our minds, let's use the literature, and let's use the patient's wishes as far as how motivated they are to try to save their tooth in order to either make the choice to treat or not. Is that fair?
That's fair. And you have to look at every situation as its own situation. And the one thing I would say for all the dentists out there that don't have 3D imaging technology, if you suspect a fracture, let's get a CBCT. And that's going to be an important part of being able to truly understand that little difference between what might still be workable and what might be actually hopeless. And so that's something that we have in our arsenal in our office. But as I've always said, if you're a GP and you're doing endo and you like endo, I'll be happy to just take a scan for you as well.
All the time.
So just know that is a possibility with any local endodontist. And it's a great way to build a relationship.
You bet. So with that, I want to thank you all for listening or watching, whatever platform you're listening to or watching this on. Brett and I, we're here for the love of endo, and we're here to elevate endodontics one conversation at a time.
Can't wait to see you inside the next episode.